You're obviously involved in future developments and research. Can you give us an outline of where you see the condition and its treatment developing over the next, say, 10 to 15 years?
Sure. Again, it depends on the component that we're talking about. When we talk about irritable bowel, for example, we have altered mucosal immune regulation. The lining of the gut can become leaky, so to speak. So medications that might affect that regulation is one area. The microflora, we talk about dysbiosis. Nowadays, we really use like a canon. We use antibiotics or probiotics, but I think there'll be more profound, more precise kinds of treatments. We just saw at the meeting here that one of the innovations is looking at bacteriophages, which are viruses that can selectively identify the bad bacteria and eliminate them. When we get into the brain-gut dysfunction, I think there's going to be a role for more precise neuromodulators that affect pain regulation. So I think these are I think we're going to look at these components and drill down on the more precise treatments for them.
So it sounds like we can be fairly optimistic about the advance of medicine, certainly in this area. You mentioned earlier your work with the Rome Foundation. It's now been in existence for 25 years. What are its developments and what do you see as the future plans for the Rome Foundation?
Well, again, the Rome Foundation, when we began it, was to fill what we call a gap need. There was no way to categorize these conditions to do research. And once we did that, the categorization led to an explosion of research that's going on now because we now have these symptoms. But it's one of the chair of the Women's Committee called it team science because we have 123 investigators around the world, all experts in these conditions. And we use what was called the Delphi message. First of all, let me say that becoming a part of the Rome Foundation is something that people really want to do if they're involved in the field. We function much like the Institute of Medicine. We identify a need, we identify the best people, we ask them to go on a committee, and we work by consensus. We call it the Delphi approach, which really means that you bring experts together. What happens? Well, in the beginning, everybody thinks they know everything, and they will say they know what's best. But after a few days, you begin to harmonize and the rough edges are evened out and you come to consensus. And that's based on evidence in the literature. And so those committees form chapters, and those chapters are the basis for understanding these functional GI disorders. The Rome books, they're 2-volume set, and the Rome books are really a compendium, a Bible, so to speak, of knowledge. Since 2010, we moved on to say we want to expand into other cultures, which I've mentioned to you. Mm-hmm. We want to expand into primary care, and we want to have an educational message. These criteria were for research and academicians. What about the practitioner? That's where we developed diagnostic algorithms. The diagnostic algorithms give people a pathway for diagnosis. The multidimensional clinical profile is for treatment, and I want to say something about that, in that having a diagnosis doesn't mean a specific treatment. Patients who are seen in primary care with mild symptoms, as I mentioned, are treated differently with severe symptoms. So we basically decide treatment based on several components. What's the diagnosis, irritable bowel or dyspepsia? What is the subcategorization? Is it post-infection? Is it diarrhea predominant? Is it constipation predominant? What is the quality of life? We have a question, how much is this affecting your life? If you have more disruption in your life, you use more treatments. What are the psychosocial comorbidities? If you have anxiety and depression, you approach that with medication or psychological intervention. And what are the physiologic components? Do you have fecal incontinence? Do you have biomarkers? Biomarkers is the big thing these days. What are the specific biological substrates that you could treat more precisely? Using that profile, we can now go on and more precisely define the treatment.